Hi, my name is Brett Hawkins, student physical therapist assistant from Jefferson State Community College, and I'm going to be speaking with you today on plaque psoriasis. Plaque psoriasis is a common chronic, inherited, recurrent, inflammatory, but non-infectious dermatosis characterized by well-defined erythematous plaques covered with a silvery scale. It occurs equally in both genders, most commonly in young adults, and can occur at any time in a person's life. Once the condition is present, it becomes chronic and it can come and go with symptom exacerbations at any time. Here's a picture, as you can see, of this guy's anterior portion of his leg, all the silvery, scaly appearance of the plaque psoriasis on his leg. That's what it looks like during symptom exacerbation period. The pathology of plaque psoriasis. The underlying abnormality in psoriasis has not yet been identified. It is a disorder of the keratinocytes, which form in the lower epidermis, and they flatten with age and they move towards the skin surface with the cells that are generated below. Normally the life cycle of a skin cell is around 26 to 28 days, and in contrast, the turnover time in plaque psoriasis patients of skin cell turnover is 3 to 4 days, which is much shorter. This shortened cycle does not allow time for the cell to mature. Thus, the cells stick and build up to the skin, resulting in a thick and flaky stratum corneum layer of the skin, which in turn produces the cardinal manifestations of psoriasis. Second component of this reaction is the immune system reaction via T cells. And these cells accelerate capillary growth by supplying the infected lesion area with blood and nutrients, therefore it can flourish and grow. Here's another picture. As you can see, this is the posterior portion of this gentleman's arms on both sides of his elbow, and you can see, once again, the silvery, scaly, kind of fishy looking plaque there. It shows up really well, and that's a common sign of plaque psoriasis there. So that's a well-defined lesion, both of them. Diagnostic procedures. Diagnosis depends on the previous history, clinical presentation, and if needed, a skin biopsy of the lesion area to rule out any other causes of the lesion, such as skin cancer, burns, or anything like that. And typically, with these two patients, they present with elevated serum uric acid levels because of the accelerated nucleic acid degradation. But the only difference here is they don't have corresponding gout with the elevated serum uric acid levels, they just have elevated levels. So that's the dead giveaway there. Medical prognosis. Psoriasis usually reoccurs at intervals and lasts for increasingly longer periods each time it presents. But advances in treatment in the past 10 years or so have really had a drastic effect on flare-ups, and 85 to 90% of cases, it can kind of take care of the flare-ups as they come and they can be controlled. Spontaneous cure is uncommon in plaque psoriasis, and the risk of infection is high and greater than normal because of the appearance of staphylococci present in psoriatic plaques because of the open lesions. So you need to really take care of the skin area and keep it protected. People with psoriasis who are HIV positive are at high risk from infection from self-inoculation. So that's another pointer there. They have to be really especially careful with those kind of patients. As many as 20% of clients who develop psoriatic arthritis, they may sustain and severe joint damage accompanying with deformity and even possibly in severe cases, disability. Common medical treatments with plaque psoriasis include corticosteroids is the main treatment. It's the most common, but it should be used sparingly. And I mean sparingly because of the side effects. So you have to kind of use it in intervals, to get the results that you need, and don't use it for long periods of times. Immunosuppressants, mineral oil, relaxation techniques such as yoga, things like that. Stress management. A lot of psoriatic patients, they see psychologists for help because it kind of plays with their mind, with the way their skin looks, and they're afraid people are going to, have something to say, and a lot of them end up having to resort to antidepressants because of that fact. Other medical treatments, and this is a big one too, phototherapy, which is basically exposure to UV radiation outside usually for around an hour to an hour and a half a day. And this really helps with the skin lesions because it tends to dry out the cells that are influencing the lesions below. But you want to be careful with this in patients that are sensitive to UV light or they are prone to skin cancer. Anti-metabolites and oral retinoid therapy are also treatments. Okay, the physical impairments that these patients will present to therapy with. Well, in psoriatic arthritis, which is 10% of patients, they will have obviously painful joints, swelling, and which could lead to further disability. They will present with dry, cracked, and crusted lesions, which cause itching, pain, and inflammation and effusion, which we all know is swelling. Functional limitations and disability. Impaired joint motion will limit ADLs, which is activities of daily living, in arthritic patients during symptom exacerbation periods because of the swelling and the pain in the joint area that is affected. In severe arthritic cases, sacroiliitis, which is inflammation of the sacroiliac joint, and spondylitis, which we all know is ankylosing of the joints, could be present, producing disability with activities of daily living, such as anything with sitting, standing, or gait, which is walking and ambulating. Physical therapy implications. Patient education is key here. You have to educate these patients on how to take care of their skin when the symptoms exacerbate, because that is key, because you don't want the area getting infected, because if it gets infected, then it can lead to other things. Client instruction and direct intervention to provide skin care at home. Steroid cream, which is corticosteroid cream, needs to be applied with a thin film, not a thick film, and apply medication only to the infected lesion area, because the cream can do further damage to regular, normal, intact skin if it comes in contact with it. And obviously, hot pack and cold pack use for pain and stiffness when patients present with arthritic symptoms. Okay? Range of motion to prevent joint stiffness. This will be key for your patients that present with arthritis from the psoriasis. You want to keep the joint exercised with passive range of motion and active range of motion to prevent fractures and things of that nature. And gait training to address compensatory strategies, which the patients with arthritis will tend to compensate with different areas and different muscles due to the painful joint and the swelling. The two preferred practice patterns that we use to treat patients with psoriatic arthritis and plaque psoriasis is 7A and 7B, which 7A is primary prevention risk reduction for integumentary disorders. 7B is impaired integumentary integrity associated with superficial skin involvement. So refer to your guide physical therapist practice for these interventions. Precautions and contraindications. Phototherapy is contraindicated in pregnancy and for anyone with abnormal moles or otherwise at risk for skin cancer. Use precaution with topical and corticosteroid use, and you need to know these side effects of these applications, such as muscle atrophy and skin fragility. Other considerations for therapy. Always monitor the skin with these patients during physical therapy. Key, potential for breakdown is at high risk for patients with plaque psoriasis. Be cautious during arthritic exacerbations and protect the joint and surrounding area. In conclusion, patients who present with psoriatic arthritis can live a normal, functioning life. With advancement treatment options during flare-ups, this disease is much more manageable with plaque psoriasis. Controlling exacerbation periods is the #1 key for normal everyday function with these patients. Okay, now we're going to watch a short little video that's going to help educate you on this disease.
Chronic plaque psoriasis. The most common presentation of psoriasis is the chronic plaque form. This form typically involves extensor extremities, such as elbows and knees, the scalp and sacrum. Red, sharply defined scaling papules that coalesce to form stable, round to oval plaques. Usually, the palms, soles, and face are spared.
And now what it's doing is it's just going to go through some different pictures of some different patient cases here. As you can see, that's the glute hamstring area, and it's really heavily infected. As you can see, the silvery and scaly presence here. And that's a person's back. So as you can see, in severe cases, it can be quite something to see.
The deep, rich red color is a characteristic feature that remains constant. The scale is adherent, silvery white, and reveals pinpoint bleeding when removed. This is known as Auspitz sign. Individual plaques vary from thick and infiltrated to thin. Similarly, the overlying scale may be thin and translucent, or extremely dense, white, and yellow stained from serum.
All right, ladies and gentlemen, thank you for your time, and this concludes my presentation.